Well, let's ask the obvious. What is AOA Dx, and what brings you to that company?
Absolutely. So AOA Dx was founded about 5 years ago. I am one of the co-founders, and I have two fantastic other co-founders, Oriana and Alex. And we had worked together for 15 years in women's health. And when we founded AOA, it was really with a goal in order to improve women's lives and women's health. So AOA Dx is dedicated to early detection of ovarian cancer. We're looking at those women who are arriving at their providers with signs and symptoms. Today, there are really no tools to help those women, and on average, the diagnosis takes 9 months. Ovarian cancer is an extremely fast growing cancer. So you go from stage 1 to stage 4 in under a year. And 80% of the disease is diagnosed at late stages, which correlates exactly to the amount of time it takes us to do the diagnosis in the US. Because the women are arriving, they have fairly vague symptoms: abdominal pain, changes in urinary or bowel movements, bloating. A lot of times it's ascribed to much more benign conditions like menopause, like GI, irritable bowel syndrome, and in many cases dismissed, or a wait and see approach is adopted. And in that case, the cancer grows. And what we wanted to do is really address this issue to bring a diagnostic test that is able to very quickly stratify the women who are high risk and need the appropriate follow up from those that it truly may be a benign condition and they need a GI follow up. So that's what AOA is focused on.
Well, as you know, a previous clinician and women's health specialist, I can't underline how important the work that you are doing is, as well as personally, as I've had actually more friends than I would like to count who have had ovarian cancer. So, for the audience, because I think, again, probably others have been touched by this as well, or may be concerned, talk just briefly about how ovarian cancer is diagnosed now and how AOA hopefully will change that.
Mm-hmm. So the way ovarian cancer is diagnosed today is this is the story that we hear from both women and from clinicians that is quite typical. A woman starts to have a number of symptoms. She will typically go to her gynecologist, and the gynecologist will take a look at the symptoms. And depending on how the symptoms are presenting, they are often sent for a GI evaluation. Let's say GI isn't going to find anything, then they are maybe sent to a psych evaluation. What published studies show is that up to 30% of women get treated for another diagnosis, like a UTI. A large number get put on antidepressants because they say it's just anxiety. There's actually nothing wrong with you. Until they finally get to an acute enough situation where they are sent to imaging. 30% of that today happens in the ER. And so women are circling through the healthcare system until finally they end up in the ER, and that's when they have their first imaging. And lo and behold, it's ovarian cancer. Other times they are after it, since it often becomes a diagnosis of exclusion, after they've went through everything else, they say, okay, let's do imaging of the uterus and the ovaries, and that's when they'll see a mass. And because it's this wait and see approach or serial testing to see, okay, we see something, but it's not concerning yet. Come back and let's see what happens in a couple of weeks. What we sometimes hear from clinicians, it can be anywhere 6 to 12 weeks, depending on the healthcare system, depending on the availability. Sometimes when even they refer you to imaging, it could be 4 weeks until you're able to get into your appointment. And so there's constant delays in care. And the way that we approached this is we said, okay, where can we understand where are the women entering the healthcare system and where can we disrupt this right now, right? Not 10 years from now, but right now, we could have a test that is reimbursed, that's part of the healthcare system, that is part of the regular flow, because the more something is different, the harder it is to include. And what the test that we have created alongside with clinicians and the clinical advisory board that we have is that a patient would arrive at her gynecologist. She would have a list of symptoms that are outlined as part of a ovarian symptom index that was developed in University of Washington and has been around for about 10 years. If the woman has these symptoms, she should be evaluated for ovarian cancer, not as the last item on the list, but as the first item on the list, as it is by far the most impactful. And they could do our test. It's called a Crivas GD. If the test is positive, it means you're high risk for ovarian cancer and you should be triaged to imaging and evaluated for ovarian cancer right away. If the test is negative, it's very unlikely that you have ovarian cancer and you can continue down the standard path. It could be GI, it could be urological, and then to understand what else is happening.
And for our listeners, where are you in the process of getting this to market?
So we have just finished enrolling our clinical trial, a very large clinical trial across the US, and we are in very active discussions with the FDA.